Okay. I'd just like to welcome everybody along to our paediatric conversations and research webinar rather. My name's Gay Dungey and I'm based in Wellington as a lecturer. And I'd just like to introduce our panel tonight. We've got Nigel Anderson from representing radiation therapy, Peter Kench, nuclear med, and Clare McLaren doing radiography. So you guys can decide who starts.
I'm happy to give an introduction. Is that what we're going with?
Yeah,
Gay?
you can go now. Yeah, okay, Nigel, there you go.
Right, so I'm a radiation therapist at Peter MacCallum Cancer Centre in Melbourne. Done the Peter Mac's in Victoria, we're the only paediatric radiotherapy centre, so we do all of Victoria and also Tasmania. I've been at Peter Mac for about 5 years, so I've had little paediatric experience until I've come to Peter Mac, and I guess having been there now for 5 years, you notice the intricacies of working in this space compared to, I guess, our bread and butter radiotherapy in an adult population. So we've undertaken a bit of research of late, looking at innovative ways to try and, I guess, improve the patient experience for us. And it's always a goal at Peter Mac, not only in research, but everything we do to try and improve, in particular this patient group, how they go about their treatment. So, and research is a bit of a tricky one. So I'm looking forward to just unpacking some of that tonight in this discussion. So thanks.
Sorry, I didn't hear you, Claire.
Oh, sorry, I was waiting for you, Peter. Sorry, hi, I'm Clare McLaren, and I'm a radiographer in medical imaging. I gained most of my experience over in the UK, kind of like 30 years of it. And now I'm in Perth and working at Perth Children's Hospital, but as a senior lecturer at Curtin University. My main job in the past 20 years has been working in paediatrics and specifically paediatric interventional radiology, but kind of a generalized experience in paediatric radiography. So I'm quite aware of the various different challenges that there is to getting paediatric research off the ground. And that's the kind of thing I'm actually quite interested in, is how we can try and overcome some of those challenges. So I'm hoping that we'll have a bit of a discussion about that tonight.
Great. Peter.
Hi, I'm Peter Kench. I work at the University of Sydney, and my experience with paediatrics is working with the nuclear medicine team at the Westmead Children's Hospital. And I've had a number of research high degree students that have done projects with the team there. So I've had some experience designing protocols and getting protocols through ethics committees, and looking mainly at issues that pertain to reducing the radiation dose in paediatric procedures. And related to that, also looking at the impact of reduced dose on image quality and seeing if there's a loss in image quality through that dose reduction. Thanks, Gay.
Great, thank you. So now we'd like to address some issues around ethics when dealing with pediatrics in research. So
on the back of, I guess, what Peter touched on there, it's a very different, I guess, ethics game when you're dealing with pediatrics. There's so many more things you need to consider. Again, I wasn't privy to this until I put my first sort of pediatric ethics submission through a few years ago. And where I work, even though we do pediatric radiotherapy, we don't necessarily specialise in everything pediatric. So we're fortunate we have a children's hospital up the road, the Royal Children's Hospital, where we did our ethics submission to, due to the expertise they have in this space. So I'm not sure what, Peter, with your experiences have been like, but you sort of need to be mindful of where you submit your work to make sure you've got the right expertise, more so than you would any other project, because it is very much a niche group. And, you know, in terms of how you design your study and all those sort of things as well, there's so many other things you have to, I guess, look to address as a consequence in this space. So I don't know if there's any more, Peter, you'd like to address. Having done this a few times yourself, you seem to be...
Yeah, sure. So I guess what's unique about children is that the issue of consent becomes completely different. They don't necessarily have the ability to consent. They're not adults. They don't understand all the issues. So we have to look at the protocol through that and ask questions about who's going to consent, whether it's a guardian that's part of that process. Sometimes we designed studies that don't require consent. So we say that it's such a low risk type study. There's no additional procedures or there's no additional radiation. We're actually taking the data and we're looking at it in a different way. We're investigating the data in a certain way. And we can ask for the consent to be waived. And that could be for prospective studies. That means studies that you're planning to do. And it could also be for retrospective studies where you take data off the database from the PAC system or the RIS system, and you do some analysis on the data in that way. So one of the things you need to consider is the ethical considerations. And I won't go into a great deal of depth. I'll let Claire make a comment, but we also have to think about dose. We have to think about sedation. Or how we're going to immobilize patients. We have to think about the amount of time that the patient is going to be in the department or having that procedure, and if our protocol extends those times. So I'll hand over to Claire to make some comments.
Yeah, I think one of the things with ethics for paediatric research is to make sure you get across the message to both the parents and the ethics committee is that you're not experimenting on their child, and trying to put it in a way that doesn't scare people off consenting for a procedure. And you mentioned consent a moment ago, and information for patients. And one of the things I found is that even though you may not be able to gain consent necessarily from a child to enter into a research project, and it's often their parents that will actually be giving the final consent, but that you have to consider still informing the child of what's going to happen to them, and if they have to have additional tests, what those tests will involve. And I found one of the things that can be quite challenging is writing 4 or 5 different age groups worth of patient information in paediatric research, where you have to aim something at groups depending on your ethics committee, which will have different kind of guidelines of what you write, but you might find you have to write a patient information leaflet that's for something like an 8-year-old, a 12-year-old, a 15-year-old, and parents. And that can be quite challenging to get the language correct. And as you mentioned, Peter, you need to think about if there's additional actual procedures required to conduct your research. So if you're thinking of doing something that adds in an extra CT scan or an extra nuclear medicine study, that will all have to be in your ethics, and will all have to be very well justified why you are considering doing a project that involves additional radiation on top of what the child would already receive. I don't know if anyone else has got any experience in writing those ethics information things.
Yeah, I think one of the other things which we probably haven't touched on also is when we look into recruitment and so forth, but randomisation is also, I guess, an added complexity in the paediatric cohort. I mean, a study we've done recently has looked at using a virtual reality to educate patients about their pending radiotherapy treatment. And we made a decision very early on in that process that we weren't going to randomise. So we weren't going to have some patients being able to access this technology, which we thought would be particularly beneficial, and hopefully be able to minimise the need for general anaesthesia, and then not give it to some. It was a really tricky minefield to negotiate, and we decided that no, we wanted to offer it to all. So sometimes the randomisation is maybe a little bit more difficult to justify in a paediatric setting, and which can take away from some of the I guess the quality of the research, because we all know randomised studies is sort of the gold standard. So but it's balancing that, as Claire said and Peter said, all those other things we need to consider with the child, beyond just the science, I guess, of the pure science. We need to make sure what's best for the child should be front of mind, and that doesn't always agree with exact or perfect research, I guess.
I think you'll find that, and when you look in the actual literature, there's very few actual randomized control trials in children, especially for radiology, radiotherapy type procedures, because it's so few numbers often. And a lot of children, especially when you work, I used to work at Great Ormond Street Hospital in London, it's a specialised children's hospital. You get the rarest of the things that happen in the world. And then if you need to try and bring in a new procedure, or you need to do some research, it's very difficult because your numbers are so small. And that's where I find it comes down to having really collaboration is where you often have to start. Otherwise you end up with research which is often maybe a small case series, which isn't research, and throw in a lot of anecdotal information that's not really got any scientific backing. But because you haven't got the numbers, it's very difficult to do a research trial that's got clinical significance in what you're doing. So I think the numbers thing is really, really important, and often how low those numbers are.
Which often adds another complexity to it. Oh, sorry, but what often adds another complexity as well is that you then have to broaden your recruitment, I guess, on the back of that, which involves sometimes more complex ethics procedures because you're going across different jurisdictions. And so, for example, we might get ethics approval here in Victoria, but then to try and get it in Perth or in Sydney, on top of that, you need to jump through a few more hoops and barriers. And even if you go international, it adds another layer again. So it sort of complicates things, but it's needed to get those numbers, as Claire touched on. Sorry, Peter, I jumped in before you.
No, that's right. I was going to talk about numbers as well. That's a consideration with a study design, is the numbers and the statistical tests and the analysis that you can perform. And as you mentioned, you can look at other departments that are doing similar protocols to you and trying to increase your numbers in that way. But as you also said, there's a complexity of multiple ethical approvals for a protocol across different states and territories because it all changes. And that makes it more of a challenge as well. So New South Wales has a fairly standard way of doing things. And there are other states that have agreements between human research ethics committees, but there are states that have their own process, and you have to go through their own process to get things approved.
Right.
That's one, as you say, one of the issues with multi-centre trials is you need the ethics in each centre. And if you are then looking internationally, that can be quite complex. And you're adding in the level of wanting to do a research study on children. A lot of ethics committees, first of all, take a step back before they'll actually look at it and go, oh, okay, maybe this is all right. So I think that having to get multiple ethics approvals is quite complex.
Yeah. So it can be quite challenging. And I guess you have to go international if you want to get the numbers of participants as well. So what about communicating with them and, like getting compliance across different age groups of children?
Mm-hmm. I would say, well, that can be a challenge. It depends what your study is, because obviously what a 15-year-old can do and what an 8-year-old can do is completely different. So I don't know how, Nigel, you find that with your radiotherapy. That might be a challenge sometimes.
Oh, yeah, it's particularly challenging. I think as part of the study I spoke about earlier, we had to develop content to show children, again, trying to find, similar to you talked about your information sheets and so forth, trying to find that balance between what's good for a 6-year-old and what's good for a 17-year-old. It varies considerably. And that's down to, communication and compliance too. So you've got to really, I guess, navigate how you best, approach the children. We were fortunate in the work that we did. It was quite appealing to most age groups of children, I guess, in terms of here's a intervention which was putting on a fancy headset and children being able to view it. It was, the kids were easy to recruit, which we found. But I imagine for more in other interventional studies, that might not be as easy to do, because you're dealing with different personalities, different age groups, different levels of compliance, which you're dealing with children who are already in a vulnerable situation, who have been through a lot before they even get to your department. So and sometimes they just had enough. And we had a number of, only a handful of patients, but in particular the older teenagers who didn't want to be involved in our work because I think they just had enough. They just wanted to go in, get their procedure done, and leave. And you'd have to totally respect that, because whereas a 6 or 7-year-old who's got a chance to do something that's really cool, like that's, so you're really dealing with various, as we've said, it's when you deal with adults, it's they're far more uniform, I guess, in the way they present you. But children, depending on what age they are, those of you who out there have children and don't have children know that they vary considerably over those age groups. So yeah, it's a difficult one, that's for sure. And communication is the key. If you can get that, if anyone can perfect communication with children, let me know, because I've got 3 of mine still got a lot of work to do in that space. So yeah, it's a tricky one.
Peter, have you got anything to add to that?
No, look, I haven't had a lot of experience myself with the communication aspect, because the studies I've done so far with pediatrics have been more about either using the standard protocol or it's a retrospective study. So it hasn't been a big issue for my research. And the other thing that's an interesting side note is, because I'm with the University of Sydney and often my research student is with the University of Sydney and not an employee of the department, sometimes we can't actually go in and interact with the students. We depend on the actual employees of the departments, the nuclear medicine technologists, the physicians, to actually do the procedure, anonymise it, then present it to us. Because there is a restriction through ethics with us interacting directly with the patient data before it's been anonymised.
Mm.
And that may not be the case with many of our members. A lot of people in the group might be working directly in the department with paediatrics. So it's a different experience when you're setting up a department that you're actually employed at, as opposed to being outside of the department and trying to do research with that group.
Mm.
Especially with paediatric data, it tends to be more sensitive as well, I think. And even though it shouldn't be any different to adult, I think it's just there's extra sensitivities that when you're dealing with children's data, it seems to be, I guess, that heightened level of we need to do this. You know, we can't afford to take any chances, I guess. Not that you would for anything else, but it seems to be, I guess, that perception which we need to be very mindful of.
I think we have to be very careful that we still manage to get people interested in doing paediatric research, because that's one of the things I've found after working in paediatrics for 20 years. It's very easy to think, oh, I can't possibly start that process. It's just going to be terrible. So I think people have to persevere and try and find their ways. And you really do have to convince people that it's a good idea to do that research. And you have to make a very good case. I think you have to almost make a much stronger case when you're doing proposing a research trial that involves children, because otherwise an adult you can kind of talk to and explain. A child, you have to get through the parents, obviously, and they're going to need convincing, and then the child is also going to need convincing, and that's after you've convinced ethics that your project is well worth doing. But we do have to find our ways around the various obstacles that are out there.
That raises an interesting point, because I hope when we talk about the barriers of doing paediatric research, we don't scare people off and they think, oh, it all looks too hard. So I might ask you, Claire, what do you think are the rewards of doing paediatric research? And Nigel, is there, because there's a flip side, right? There are definitely a great deal of satisfaction knowing that you're helping these young lives and young people.
I think part of the things that I've been involved with in children in interventional radiology is things like performing renal angioplasty or aortic angioplasty. And a lot of people think, oh, you can't possibly do that in children. Well, we've done it in children down to less than a week old, 700-gram babies who've had angioplasties of their aortas or their renal arteries. The problem is nobody makes equipment for children of that size. So there is 100 different stents on the market for anybody of our size. Any one of us that's on this thing, you can go out, you can buy a stent off the shelf and it will fit your artery. All the devices in children are off-label. That adds a complexity, especially if anything goes wrong, because then you're at the risk of somebody saying, well, you used a device that hasn't had any research done on it in children. So to me, getting over some of those barriers would actually have equipment designed for children, so that when you have got something really complex to do, you can go, actually, yes, we have the device and it's perfect and it's been tested in children. So at the moment, one of the issues obviously with putting in, say, a stent into a child is it doesn't grow with a child. And that child has got a long way to grow, especially through doing a procedure in a baby, all the way through to being an adult-sized person. But the research just isn't there. So for me, having some research on devices and equipment that you can use in children would be really beneficial. And just to come out with a standard range of things that you could then use in a child that you know has been tested and is safe, rather than having to use something that you think, oh, well, it was safe in adults, it will probably be safe in children. So that's what I'd like to see.
I agree. I think in the paediatric population, whilst it can be confronting and difficult and challenging, I think the potential benefit on the other side of it is that you've got these patients that are going to live, in particular in radiotherapy, and a large majority are living many, many years beyond their treatment. So the ability to make a difference in one, whether it is, it might be limiting the amount of radiation you can get to normal tissues, which enable them to develop, as close to normally as possible beyond their treatment, is a pretty compelling one to justify why we do what we do. But also in terms of stuff we've done in regards to patient experience, to be able to get them through their treatment without some of the mental scars that may come with it. It can be quite confronting experience, for example, getting a mask made, or having to get general anaesthesia every day for the course of their treatment, the side effects that can come with that. I think the ability to try and make a difference, if it's only in one patient, I think it justifies what you've done, because, as Claire said earlier, they're very small patient populations, so you're not dealing in these huge, in most cases, huge studies. So to be able to make a difference in a patient that generally you get to know quite well, because you are navigating so many more complexities, you're getting to know them and their families probably more than you would maybe other patients along the way, because you're having to deal with many more issues and complexities with them. So I think to be able to see that benefit, in the work that I've done, you'll be able to see that benefit in patients firsthand. I think that's as much motivation as you should need, really, to do what we do, because even if you see one child benefit from the stuff that you've done, simple or as complex as it may be, I think that's worth its weight in gold. So I think the risk reward is a lot larger, I guess, but I think the benefit at the end, if it's done right and you undertake the research well, I think it's a huge win. It's a very satisfying feeling, I guess, at the other end.
Yeah, I'd see the advantages. Building on something you said, Nigel, a lot of my work has been related to trying to reduce the dose or understand the dose that paediatrics receive, particularly related to the injected dose that we give, for example, FDG, fluorine 18 in the PET scans. So we've done studies where we've looked at reducing the dose and checking the image quality with the nuclear medicine physicians, and we've found that you can bring that dose down quite a great deal and still have images of good quality for reporting. So, and we know that when we reduce the dose, because of the lifespan of the child, the longer lifespan compared to an adult in their 50s or 60s having studies for oncology, having a paediatric having studies for oncology and the dose that they receive, we know that there's more chances for that dose to have a detrimental effect because they're living a longer time. So it just makes good sense that if we can get the dose down low for these young paediatrics at this early stage in their life, we know the benefits will pay off in the long term.
On that, Peter, we have a late effects clinic that runs at Paediatric, which I'm sure most paediatric centres do, which is looking at patients who had radiotherapy, 10, 15, even 20 years ago, and then are still coming back for follow-up. And we're still seeing impacts of that treatment that was delivered far less conformally to what we're able to do today. So to be able to see that and know that what we're doing is potentially going to benefit someone, 20 years down the track, I think, it's a huge carrot for us to continually improve what we do, because as we've said a couple of times already, these patients are living for a lot longer than what your 60, 70-year-olds you might be treating prostate cancer or breast cancer. So we have that, I guess, increased obligation to make sure we dot every I and cross every T to make sure we do as best we can.
I think, as we've said, radiation dose is obviously really, really important, because these kids, we are all hoping, live till they're 70, 80 or 90 or whatever, and they've got such a long time to live with the consequences of us over-irradiating them for whatever type of procedure it is. But I think some of the dose projects are actually really good kind of research starting points for a lot of people. Certainly with medical imaging equipment, a lot of them don't do very good pediatric protocols. So when you get your new CT scanner, often there needs to be quite a bit of dose optimization done, even to the pediatric protocols the companies have set, because they want you all to produce wonderful images. And the best way of producing wonderful images is to give a lot of radiation dose. I mean, you can get the most beautiful pictures if you throw radiation at them. So there's a lot of kind of areas where radiation dose can be tweaked, even just from the presets that the company have. And I think that's where it can be really good in departments where you can actually think about how you could look at your radiation dose and what type of projects you could set up that wouldn't need ethics, doing even image review, where you just look at the last sort of number of certain CTs you've done and what parameters, and how good is that dose. I think there can be some really easy starting points when you're looking at some of the radiation dose optimization things.
We can do the very, very similar things in radiotherapy. We've got patients that have been treated in particular techniques, and we're always looking to improve that. So for radiation therapists that are listening in, there's planning studies you can do. How can we improve this technique based on what we currently do? And that's something, again, which is very easy to do. It's looking at retrospective data sets. So the actual impact on patients and the ethical requirements are very minimal. very minimal. So I think that's something that we can always look to try and do. We've got information there ready to be looked at on a daily basis. So I think that's something that we can always look to improve again, to try and constantly get better. We have this new equipment quite often. We've got at our disposal. We're getting new treatment planning systems. We're getting new treatment machines, new radiation therapy linacs. So we need to try and maximise or optimise their use, and that's done through things like planning studies and smaller pieces of work, which any RT can do. It doesn't require a extensive history and research, that's for sure.
I mean, I did a just an example of a really simple thing that I did with looking at cone beam CT in heads for head scanning for following vein of Galen embolization, where we had to give really quite a high radiation dose. So I went out and bought a small melon, and the small melon was about the size of a baby's head, and then just did multiple different cone beam CT settings on that, and then got the radiologist to look at the seeds in the melon and how clearly they could see them and what they thought. It was purely observational. It had no scientific merit, but it allowed us to think how we could reduce the radiation dose for those children that were actually getting quite a big dose of radiation every time, and they were having multiple embolizations. So they were getting 5 or 6 or 7 of these in a year. So we were able to kind of bring down some of the parameters and do it slightly differently. So it doesn't even have to have the child in the beam.
Right.
I guess there's some good phantoms too for those types of studies that have various imaging. I love the melon because it just makes you think of, you know, the flesh of the melon being like the brain and the seeds being certain structure you're trying to identify. But yeah, there's good phantoms that are available, and dose studies in nuclear medicine is much easier these days with current equipment because we can acquire our data in list mode, and then we can go back later and actually remove some of the counts out of that data, reconstruct it and present it. So it's like simulating giving less injected dose, but we're not actually doing it. We're still giving the standard injected dose. We're just taking data out in a very random, organized way. And it looks like you've injected half the dose or 75% of the dose, and then you can get the physicians to look at that and make some sort of assessment of its quality.
That's really interesting, isn't it?
Yeah.
Again, a good thing to do.
Be nice if you could do it on CT, but maybe in the future, not just now when you've got CTs at photon count. That would be a great way of doing it.
Yeah. There's a question that's actually just come up on the chat that's probably appropriate to address now. And that's what are some of the techniques used to convince parents/caretakers in regards to the dose not having lasting impacts on their child, especially when the research is long-term?
That's a very good question.
I think in our job we're always explaining dose, right? Every time we give a scan to adults or children, we're talking about the dose that they're and trying to give it some kind of perspective. So I think once again, you're doing what you normally do. You have to sort of give the dose perspective, talk about potential risks before you've actually talking to the patients or the parents. You've had to convince the ethics committee that the amount of dose that you're giving is a safe level, and it's the risk versus benefit is appropriate. So I think you've already made that case already to the ethics committee, and then you need to make that a case to the parents. It'll probably be in the patient information that you need to give them for consent. Yep. So you probably already covered that, and in talking about the potential increased dose if you're doing an extra interventional procedure. But a lot of it's not about dose. I guess sometimes it's about patient time, just taking more time to do things as well. So you need to consider that as well. And time has impact on patient movement and compliance and comfort. So those issues need to be considered as well.
I think this is also where you have to have, it comes down to the information that you write. And when you write your ethics application, usually you've got a section that you have to write in lay terms. And it's how good you write that lay term section, because that's what you're going to base your information on. And having really good, clear information around potential kind of complications, that if it was radiation dose or impact of having additional cannulation for an injection or something, and having really clearly written the risks and benefit for that particular child, but then the benefits for children in the future. And a lot of people, even if because their particular child may not benefit from that exact research trial necessarily, and it's getting across the benefit that there will be in the future, but without there being any risk or harm to their child. And I think it comes back down to really carefully written information that is also given to the parent with plenty of time for them to go away and read it and digest it, and then come back and ask you questions, and not rushing that consent process for research.
That's an interesting point, because my experience with adult research, we had a protocol where we needed them to consent basically on the same day. Luckily, with nuclear medicine, there's often a delay between injecting the pharmaceutical and the imaging. But that became problematic, right? The ethics committee said, have you given them enough time to think about this particular protocol and the considerations before they consent to it? And as you said, in pediatrics, the protocol may need to be done in a way that they have that time, that you introduce them to the research protocol, and when they come back next time, they actually can choose to or not to have that procedure.
I think in radiotherapy, we're dealing with a different beast almost. Our idea of dose is quite a significant jump from what I guess diagnostic pediatric work is. So in terms of we're always trying to reduce the dose we give to sort of normal tissues, obviously that are adjacent to areas of concern where we need to give radiation doses that can control and hopefully cure the tumours. So, but there is instances where we're looking at introducing more diagnostic imaging to support. That might be the accuracy of our treatment. So we're doing additional scans prior to treatment to make sure what we deliver, being a high dose of radiation, is actually accurately delivered. So I guess it's a different conversation, I suppose. Like we're trying to, I know I always liken it to, we want to make sure that we're giving this high dose of radiation accurately, but in order able to do that, you need to make sure that you're verifying what you're doing, which in turn requires some additional radiation in a diagnostic form. So when we're comparing therapeutic dose of radiation with a diagnostic dose, it's poles apart. So it's probably maybe an easier conversation to have, I guess, because relative to one another, there's such a huge discrepancy. But yeah, it's still in a pediatric setting, you need to justify. So are we doing this imaging? Do we really need to be doing it? But I think that conversation is probably a little easier to have because of what we're doing on the back of taking that extra image that's actually going to help us guide what we do. But yeah, it's still not because you still do get those questions though, which hopefully the radiation oncologist has answered in the consultation with the patient first, but not always. So yeah, it's still something that needs to be, we need to be very mindful of.
Do you have like research teams or data managers that manage some of that information to patients within the departments?
So when I was working at Great Ormond Street, we didn't really have any data management people. We did have people who would assist with writing the information. So they would at least assist you. I had to do an ethics proposal, and I had basically a stab in the dark at writing for the different levels of different age groups of children. But then we had somebody who was kind of specialist in producing information leaflets for the hospital. So if you wanted an information leaflet about central venous access, you had to have different levels of that, that just as general information. So those people were available to us to assist with that, and they could help you write for an 8-year-old or write for a nice, intelligent adult.
Yeah, we're fortunate. We've got the Royal Children's Hospital up the road where we can tap into a lot of that expertise, and part of our study team for the project I've spoken about had some psychologists and clinical psychologists from the Murdoch Children's Research Institute. So we had a lot of their expertise, which they utilised. Well, they had extensive experience in this space, so we were fortunate to be able to have them assisting, in particular that information provision procedures. But in terms of I guess those discussions with patients, it still very much should be clinician-led. I think we should be leaving those those conversations with people who are the ones who should be having those conversations. And if that should be done in our space, I think by the radiation oncologists, they should be, there to answer any questions. If they need to get expertise from other groups, fair enough. But I think we need to be mindful of who's giving that information to the children as well, to make sure they're actually, and their families, to make sure they're the most appropriate person to be delivering that information, so that it's appropriate and not ill-informed. So yeah, it's a tricky one, but I think by the time they get to being introduced to in radiation therapy setting, by the time they get to a study or a point of study, they've actually had that discussion with the radiation oncologist first. So hopefully we can dodge a lot of those really difficult and very meaningful questions along the way, because that should have been covered in that, the consent process.
I think also, again, it comes back to a little bit of collaboration of within the hospital, of who you have on your team, your research team, and having the right people. So I think you can get really good information. If you work well with your radiation physicist and your play therapist, or just the key nurse who deals with that group of children, can be really helpful in the writing process as well as in the implementation process of a project. Because once you've got people on board, they're far more engaged and they want it to work. And I think having a good team of people, not just a radiographer or not just a radiation oncologist or whatever, having that team of people that can really kind of be interested and promote your research and get that good information out there.
I think ethics committees will also tend to look at who's doing that consent process as well and scrutinise that as part of the process. So it's something you really need to have thought through before you launch a study and get approval. You need to think, what role am I playing? Like, what role is this person playing in the process? Because if you put up a proposal or a research protocol to be assessed by a committee and it's very unclear as to what the recruitment process will be and who'll be doing that, and the consent process, that will often be thrown back at you with, please clarify. So I think that's a really important step, that you can't just go flying blind day one of your trial and a patient coming in and say, right, who's going to do this consent? It should already be detailed and be known prior. So and if you've got that down pat, it should be fairly seamless in most cases.
Yeah, hopefully.
Hopefully,
yeah. And ethics committees are really good at working through those issues with you. If they see a gap in skills or some sort of greyness as far as who's going to do what, they'll get back to you and they'll say, this isn't correct, or this needs to be adjusted. And so the protocol, the whole ethics process does take a long time, and it feels like you're going back and forwards, but you really do end up with quite a good quality, solid protocol at the end, because you've had quite a good group of professional, not always in your field, but professional people looking at your protocol and thinking about the important issues. So it does refine things before you just go and before you start your study, which is a great thing.
The benefit of ethics committees too is you get the lay person. Quite often there's consumers sitting on ethics committees as well, which they look at it very much from a patient perspective. And if they were to be that patient going through that process, what would their expectation be? So it really gives us the fully rounded, approach to these protocols to make sure they're refined from each and every different angle along the way. So, which is, as Peter said, it can be time consuming and laborious at times, but at the end of the day, you're going to get a project or a protocol at the end, which is, refined and suitable for your group, in particular a paediatric group, which is more vulnerable than the other ones we face. So.
And yeah, it's good because they effectively go through it with a fine-tooth comb, don't they? And they, as you say, they kind of pull out all the issues that may come up, and in fact actually stop you stumbling when you're doing your research, because you've had to go away and think about it. They'll raise a question, as you say, like, well, who's going to get consent? And you might be going, oh, actually, I hadn't really thought about that. And then it really makes you think about what process you're going to have in place and how you're going to make it work.
Yeah. And I guess the lay people on those committees kind of bring in the public perception as well. Yeah.
They're often the toughest people to please, because they ask the difficult questions. They ask the questions that the parent would ask or the child would ask, rather than the medical question. That's
why it's so important these days. There's a big, movement of late to have consumers involved in research applications and grant applications, for example, but not just as a token having a consumer there, but actually have them involved in the research design right from the get-go, so that these things are being considered right from the start. So I know we've gone through that grant process, and having them involved has been really valuable, getting their expertise. And they do make you think about things that maybe you sort of overlook because you're getting so excited by the science and the potential benefit at the other end. It's, well, going through this process is a patient and a person, so we need to consider them as well. And that's where consumers and ethics committees can be really beneficial in making sure that that's thought about as early in the process as possible, because you don't want it to be too late by the time they become involved, and that being too late when you start the study and you think, oh, if only we'd done that, or we'd thought of this, and quite often the horse is bolted. Then you'll need to go back to ethics and maybe change something. So the earlier you can get consumers and the lay people involved, the better.
What are some of the other, might be worthwhile thinking about, what are some of the other challenges other than dose when working with paediatrics? I think I might have mentioned some that relate to if your procedure requires immobilisation. Some of the things that we've come across related to recruitment is that some diseases that we're looking at or some conditions only happen in a certain age group of patients, or it's quite rare, so it's hard to get the number of patients. And we've talked about multi-centre trials. So there are other things that are unique to working with kids that we may not have mentioned yet.
I think we touched on compliance earlier, didn't we? You know, you might sign a child up for a research project and they're really happy to do it on Monday, but by the time it comes to Friday, they've just had enough.
Yeah.
So I think compliance can be difficult, which is why, you know, it's having somebody that can talk to them and explain, you know, keep them on track, keep them interested is really important. But I think compliance can be quite challenging.
I think you need, if you on that point, if you can incorporate some flexibility into your research studies as well, so that it can, I guess, counter for situations like that. And Claire mentioned Monday to Friday, but it could be from, you see them at midday and by 12:30 they don't want to do it. So if you've got some sort of flexibility, that can be particularly helpful to make sure that you know, obviously with small numbers, you want to try and recruit as many as you possibly can. So being mindful of that and setting up studies that are going to enable that kind of flexibility within reason, so that everyone has the, I guess, the maximum optimize their opportunity to be involved is particularly important as well. I think some of the other issues, Peter, on dealing with, I guess, paediatric patients is quite often the teams that you're dealing with are far more comprehensive, I guess, than maybe you would be dealing with in an adult population. Paediatric patients, they'll have their doctor, their nursing team. In radiation therapy, there might be music therapists involved. There could be specialised paediatric nurse consultants. There could be play therapists. They have a team that might come across with them from another hospital. We have them coming across from the Children's Hospital. So there's quite often many more stakeholders involved in the whole process, which is good because they're getting a really well-rounded team looking after them. But making sure they're all communicated to and staying involved is particularly important. So if you're going to be doing something additional to their normal care, for example, it may mean they get back to their other, or where they're coming from half an hour later, it might mean that they're missing another appointment. So it's really important to communicate with their entire team. And as I said, there's many more people that team encompasses. So having good lines of communication with not just the patient and their family, but their immediate treating team to then expand beyond that is really important as well.
Do you very often get people like the play therapists and things involved?
We have music therapists, which are routinely involved at our centre, who work with the children regularly. They're there quite a bit. We have our paediatric nurse consultants who are there with them, and they're their touch point across their whole radiotherapy journey. So all information will sort of go through them, and they'll coordinate their care as well. But we also have a paediatric movie program as well. So we've got a radiation therapist who develops movies for the kids as part of their care as well. So they turn them into superheroes and incorporate that as another additional tool to help them get through their treatment, which is fantastic. But we also need to consider them, so they might have an appointment with them, which we're unaware of. We also have mask painting as well for the kids that have masks. So we offer all these additional things, which is great, but we need to be mindful that when the time is, in particular, as Peter touched on earlier as well, that the time that we're going to have them in the department all these additional things, whilst they might be beneficial to the child, it also means more time for them. And sometimes they get to a point where they've had enough. And I've seen it many a times where they've been in the department for 2 or 3 hours and they just want to go home. So you need to have a bit of that flexibility. You can just say, yeah, no problem, off you go, and not be too caught up in you having the perfect, complete set of research data that you can work with. You need to be mindful that that's maybe not always going to be the case, and be accepting of that the child should always be number one, and what their wishes are, should be always considered first.
I think, and also with the time issue is just the family as a whole. So if you've got something that is quite time consuming to do, that's additional on top of what they would normally have, many of these children have brothers and sisters and extended family, their mums and dads, and they've got to get the other kid from school or to ballet class or any of those things that children do. They're really kind of important. Again, that's another time issue. There's the whole you always have to think about the child and then the family unit as well, and you always have to be mindful that what you're asking someone to do has implications on quite a lot of other things. It might have implications on their schooling, or just getting their homework done, or when their exams are. All this, it's a huge number of things that you have to kind of at least have in the back of your mind, even if it's not fully built into your protocol.
You're dealing with everyone. You're not dealing with someone who's driving themselves in for their treatment or in for their procedure. You're dealing with.
Yeah.
Now we get ones that in Victoria that come from regional Victoria or come from Tasmania. So whilst it might be mum and the child coming in for treatment, they could have another parent and child back home, which you need to consider as well. That they're hoping to get back for it might be a basketball grand final or a music concert or something that they want to try and consider. So you're always juggling. Whilst you might solve one problem, another one will bob up along the way because there's so many other pieces to the puzzle you're trying to consider, and research just adds another element to that. So yeah, it's particularly challenging, but usually you can do it, but it just requires a lot more, I guess, navigating of different circumstances.
Yeah. So looking at time, have you got any sort of final statements that you'd like to sort of summarise with? We've got another question actually before we do that. Do ethics committees also heavily consider things like the parents, MIT having to gown up in lead? Oh yeah, that's a good question. Each time there is issues with the child being compliant, or similarly for sedation for CT or RT, given that each child is different. So
unfortunately, from my point of view, working in paediatric interventional radiology, many of our children were asleep with general anaesthetic, so that aspect of it wasn't so much of a problem. But I think it would have to be written into the I would recommend it is written into the research protocol and consequences of, because if a parent is having to get into a lead gown much more often, you've got two issues there. You're actually asking a child to have many more x-rays potentially, but also you unfortunately do have to think about you can't injure your parents, so it needs to kind of be into the protocol. I would always write something like that into the protocol, and if you expect that the parent would receive an increased radiation dose from having to stand next to their child for procedures, then that would absolutely have to be in the ethics protocol. And you may well find you have to monitor those parents with like immediate readout dose meters or something.
right.
Yes, we're fortunate in radiotherapy. Whilst we deliver the largest doses, that almost means that that's not an option for us. So parents are never in the room where there's radiation being delivered or even imaging taking place. So it's not really a consideration for us because of that, because it's just a non-negotiable. So I guess we're not faced with those similar issues maybe the diagnostic studies would require.
Adds to the picture though, doesn't it?
And the other thing I was going to say, actually just looking at the question about things like sedation, then yes, again, of course, if you think the particular procedure, the child has a potential of not being able to comply and would need sedation, then again, it would have to be in the protocol.
Yeah.
as a kind of option. So you often may have to put in options into your protocol that, you know, if you think that 85% of the time you can do this child with do the procedure on the child with no sedation, but there might be an instance where they do, then that would have to be like an additional thing in the ethics. You'd have to say, we would expect this to be able to be done without any sedation, but in case the need arises, blah, 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 yes, we would have to do it. So again, it would just have to be in your protocol, that option.
That adds another complexity with consent as well. If someone's under sedation, where does consent sit as well? So that will often raise another set of questions in response to that. So yeah,
the length of sedation needs to be considered as well. So if you've got a procedure that becomes longer and the sedation becomes longer, then that's a consideration because of I guess, an associated risk.
Yeah, and that's from projects I've been involved in that we've had to add in a certain amount of additional general anaesthetic and then get an anaesthetist to talk about the risks of additional lengths of anaesthetic. So again, it's another layer of somebody that you need to communicate with and get information from and help from and support from. Because if you're doing a research procedure and you say to the anaesthetist, oh, actually, I need you to give an extra 10 minutes of general anaesthetic, they're often not happy if they've not been informed and know what's going on. So again, it's down to writing a really good ethics proposal. And
communicating well with your teams is in addition.
Yeah.
Just on that note about getting additional, I guess, sign off, I know for all protocols that come through our research committee where there's additional dose required, it gets a medical physics report explaining the additional dose and what sort of that is comparable to, I guess, compared to the norm. So that's always done for any studies that requires extra diagnostic scan or additional radiation for whatever purpose that may be. It's called a radiation dose report, and that's signed off by an approved medical physicist who will, I guess, quantify the additional dose so that the ethics committee, when they're reviewing, they can see that, okay, this is what the average person who's coming through without the intervention will be getting versus those who are getting intervention and what the difference is. So they can really, I guess, break it down for a lay person. Because when we throw around some of these numbers, for us, they make sense, but for a lay person or ethics committee, they might not. So I think that's one thing that we do quite well. And I would imagine most ethics committees, if not all, will do exactly the same in regards to that.
Okay. Well, thank you all very much. Have you got like a final statement you'd like to leave the participants with?
I think I would say don't give up. If you think of, and if you've not done any research before and any research in children, start small. Find a little project that gets you confidence and gets you communicating with children more and their families, and just persevere with it. Really, there's lots of good projects that need to be done.
Thanks, Claire.
You touched on communication there, Claire. I think being able to communicate with the kids and their families is probably the most important thing with conducting research with this population, is to be able to engage with them and get them on board and make sure they trust you. And because that's a really big, probably more so for the parents and the child, if they've got your trust, they I guess can see the value in the work that you're doing. That's probably the most important thing, because without that trust, they won't let you go near their children. So it's particularly important to get those relationships and that communication down pat as early as possible, so that you can then go ahead and do the great work that you're always striving to do. So
yeah, just to remind everyone too that we've talked about a lot of the challenges which can be rewarding solving those challenges, but to also keep focused on the impact we can have on these young lives and the quality of life that we could improve. And it could just be about improving the time that they spend in the department, so it's less traumatic and more enjoyable. Or it could be just improving health benefits long-term, immediately and long-term, through the research that we do. So whilst the challenges are there, the rewards are high as well.
Yeah. Great, thank you. So we've probably got a couple of minutes. If anybody who is participating in this webinar would like to ask a question, then please feel free. Well, we've still got the panelists here. You can just unmute your microphone and ask away. No. Oh well, I'd just like to then thank Claire, Peter and Nigel very much for your time. It's been very inspirational. And yeah, thank you very much.
Thank you, everybody.
Yeah.
Thanks, everyone.
Thanks, everyone.
Okay.
Thanks, Gay.
Okay.
Thank you. Bye.